Should we start?
Yes, sir. Good evening, everyone. A warm welcome to all the respected faculty members, residents, and delegates joining us across the country. Welcome to IAPS NextGen Lecture Series, session number 34. Today's topic is congenital diaphragmatic hernia. It is a high yield and clinically important topic, especially from the exam and practical point of view. Today's session will be moderated by myself, Dr. Aditya Biradar, a third year MCH resident from AIMS Patna. And it's my honor to introduce you today esteemed speaker, Dr. Vijaidatta Upadhyaya, sir, a distinguished pediatric surgeon, currently working as a professor at prestigious Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Sir has made significant contributions in IAPS, from including being a core committee member from the IAPS, and he has also formulated IAPS guidelines for COVID-19 pandemic related to surgery. Sir has also been invited as a guest lecturer in many national and international conferences. Sir has many fellowships to his name. Few of them are like Japanese Surgical Society Fellowship, Fellowship in Minimal Invasive Surgery from Berlin, and Fellowship of FIAGS and FMAS. Sir, we are truly honored to with have you with us today. We look forward for your lecture. Without taking much time, I now invite Dr. Vijay Datta Upadhyaya sir to begin the lecture. Sir, the screen is yours.
Thank you, Adish, for your warm welcome and for the introduction. First of all, I will thank you, Aditya, to you and Deprabha, who invited me and given
Sir,
me
honors.
the opportunity to present this thing. So, warm welcome from SCPCI Lucknow. Though it is a winter and I think 9 o'clock to 10 o'clock, it's one part of India, it's too late. So I requested Deepava that we can distribute our or conduct it in two steps because in this step one class it's going to be a much longer, maybe around 1 hour 30 minutes or 1 hour 25 minutes. And Deepava graciously given me opportunity to give it, present it in two parts. So first part we will describe the. It is not working. Yeah. So learning objective for this is introduction, development of diaphragm, development of CDH, mainly focus on the prenatal diagnosis and its differential diagnosis, and then the prenatal prognostic indicators, prenatal management, and fetal intervention. One thing I want to disclose, I have used several photographs from that net, for which I have given the due notification and acknowledgement to the places where I have taken the photographs. So coming to the epidemiology, it is incidence is 1 in 2000 to 1000, 1 in 5000 birth. Most commonly, it is seen on the left side and around 10 to 15% on the right side. Bilateral CDS are known, but they are very lethal and a high incidence associated with anomalies. Infants with isolated CDS are more likely to be premature and are mostly male, and 1/3 of them have associated major defect, which we will discuss in subsequent slides. So, what is CDS? CDS is a defect in the diaphragm on which the abdominal components or parts herniate into the thorax. So, I have already told the incidence of the worldwide, but the incidence in India is 3.8 in per 10,000 live birth. And 40 to 60% are associated with other anomalies. And itself, it has a poor prognosis. But for the low income or middle income countries like India, it is almost 59%. I think I'm audible. Hello?
Yes, sir.
Yes, sir. It's on.
So there is a study from in the Indian Pediatrics in 2019, from which I have taken the data that the poor survival in India, it is almost 59%. Survival only, whereas the rest of the body is more than 70%. So coming first to the development of the diaphragm. The diaphragm develops between 3 to 7 weeks of embryogenesis, and it is formed by several structures, of which septum transversum is the most important thing, which appears at around 3 weeks of a gestation, and form the central tendon of the diaphragm, which is the most important and toughest part of the diaphragm. Initially, this is located in the cervical region, and with the development of the fetus, it descends with heart and liver to the position which is seen in the middle of the cavity. So you can see here, this is the septum transversum, and then comes the second important structure, which is pleuroperitoneal membrane. So the closure of pleuroperitoneal canal completed by this membrane. This gap is this pleuroperitoneal gap is the gap between the abdominal cavity and the thoracic cavity. Complete separation of thoracic abdominal cavity is done by the pleuroperitoneum membrane, which you can see here. I am marking it by my cursor. In the middle, it is the septum transversum, and on either side, it is the pleuroperitoneal membrane. And then the dorsal mesentery of the esophagus, which form the right and left dura of the diaphragm. And then in between these, the muscular ingrowth from the body forms, that is the mesoderm of the body, makes the major part of the diaphragm. And then the phrenic nerve C3 to C5 innervate the diaphragm due to its cervical origin. So this clears why it is innervated by C5 to C6. So coming to the flow diagram, the first is the septum transversum, which we have seen. It is seen usually at the age of 4 to 5 weeks. Then there is pleuroperitoneal membrane closure, and then the dorsal mesentery of esophagus come into action. And by age of almost 12 weeks, you can say that the diaphragm is fully developed. So here you can see which I have described as a central tendon. This is a pleuroperitoneal canal, and this is the space of Morgagni from where the Morgagni hernia do occur. And these on the posterior lateral side are the pleuroperitoneal canal, which if the membrane doesn't fuse, may lead to the defect, which lead to the formation of Bogdell-like hernia, that is posterior lateral diaphragmatic hernia. So when we have to diagnose CDH, so suspicion occurs when during routine second trimester anomaly scan, we are not able to see the stomach bubble in the abdominal cavity, or when we see, or when the clinicians see that the stomach cavity or abdominal cavity is smaller or equal to the size of the thoracic cavity, and he is not able to see the stomach bubble into the abdominal cavity. Suspicion also arises when you see the polyhydramnios, and as I told you, the small chest and large abdomen. So polyhydramnios, coming to the polyhydramnios, what is polyhydramnios? This is the question which is usually asked when you say that polyhydramnios is there, or when the antenatal scans can show polyhydramnios. So first is the amniotic fluid index. How it is calculated? It is divided into 4 parts, and each part has given a number. So the largest pocket, which has a depth of more than 8 centimeters, is calculated, and amniotic fluid volume of more than 1500 to 200 ml is considered as high polyhydramnios. So at least 2 diameter pockets are taken. As you can see here in this picture, there is polyhydramnia because the AFI, which is calculated, is 32.24. So any AFI which is more than 25 centimeter is indicative or is shown or called as polyhydramnios. So it is one of the important features, but it is not very specific for the diaphragmatic hernia. It can be seen other causes also. So first thing, when you see a polyhydramnios, you will be all one of the suspicion. Now, when you are doing the ultrasound, you can see this is on the left hand side. There is a coronal view in which there is hypoepiphytic lesion, which is the diaphragm. So this is a normal view when you are seeing to a diaphragm. If you are not seeing this, and this fluid structure, that is stomach, can be seen here, and this will lead to the or suspicion of a congenital diaphragmatic hernia. The hallmark of this is the presence of fluid-filled stomach in the thorax, just behind the left atrium. If you are able to see it, it is 100% diagnostic of diaphragmatic hernia, and you can comfortably confirm it by doing the Doppler when you can see the heart and the stomach shadow just behind it. Then this, once we have that, defined it, then another thing by which you can diagnose it by the fetal MRI, but it is more rarely done when it is the suspicion is high, or when you are thinking there is other anomalies, then fetal MRI is usually done. So this referral technique for the fetal lung volume, it is done very shortly. A highly reliable measurement of both lung can be done. We will discuss it in subsequent slide. So coming to the antenatal differential diagnosis. Diaphragmatic eventuation is one of the most common differential diagnosis for diaphragmatic hernia. But thing is that it is very difficult to identify on the antenatal scan. So it is practically it is not differentiated between, you cannot differentiate between the diaphragmatic hernia or eventuation of diaphragm in the antenatal period. Second comes the congenital cystic adenoid malformation. As you can see in the photograph, that this is a fetal lung, and there is a anechoic area which is can multiple cystic areas can be seen. It is one of the diagnostic features for the cystic CCAM. Now in another chamber, when you can see that most important view is the four chamber view. That means when you are able to see all the four chamber of the heart, that view is considered one of the perfect view to diagnose the lung lesion as well as the congenital diaphragmatic hernia in this case. As you can in this season, there is a large cystic area on the right side of the lung. Left lung is looking normal. So these are the cases where you can have to differentiate it from the congenital diaphragmatic hernia. Next is bronchopulmonary severity. As you can see that the anechoic area, anechoic area that is the sequestration. When you suspect this type of lesion, you have to do or use the color Doppler, and you can able to see the artery supplying to the lesion. It is diagnostic of pulmonary sequestration. Next is the bronchogenesis. In this case, again in the four chamber view, you will see a large cystic area, and this single large cystic area will be differentiated easily by the congenital diaphragmatic hernia. So, how the antenatal CDH, why and how it is important? So, the things which are used to assess the severity of CDH in antenatal period are the things which we use is the high resolution ultrasound, which is usually done at the most of the center. If some abnormality is seen, then we use the fetal MRI scan. And then if fetal MRI scan is showing some abnormalities, then fetal echocardiography and genetic testing are to be done to counsel the parents for future gestation and the delivery of the patient. So the antenatal CDH, we should consider what are the things which has impact on the ongoing child or during the postnatal period, how the patient will behave or the baby will behave. The first thing is the associated anomalies. Associated anomalies usually have a poor prognostic factor, and the associated factors which are found is almost 30 to 40% of the cases, and most common are the congenital heart disease, followed by neural tube and renal anomalies. Now, the bilateral CDH we will discuss in subsequent slides, syndromic cases, familiar cases, and then comes the one of the important thing is associated genetic abnormality. So genetic and chromosomal abnormality is seen in 15 to 20% of the cases, and testing is recommended if you are doing karyotyping or microarray. And the poor prognosis is seen in the trisomy 18, Pallister syndrome, and Char syndrome. Pallister syndrome, there is mental instability, fragility, and all these have associated with congenital diaphragmatic hernia. Fryns syndrome is a disease which is very pliable with the hair, scalp is rarely having the hair and is very unstable condition. Usually these patients die in the during the antenatal period only, and they have if they deliver, they don't have the toes or the fingers in the hand or the foot. So these are the anomalies which are associated with poor prognosis, and then comes the severe congenital heart disease, which is associated. Mainly, it is assessed by Doppler. taking consideration into the pulmonary artery size, pulmonary artery Doppler waveforms, and worse prognosis is seen if small left ventricle is seen in the antenatal period or reduced cardiac output. But do remember, these things are difficult to conduct and it's to be done by very, very specific endocrinologists or the fetal genetics persons. So, so what are the indicators for poor prognosis? So one of the thing is age of gestation as a diagnosis, amniotic fluid volume, as I have already told you. Then comes the laterality of the hernia, then position of the liver and the division of the umbilical vein. Next is the stomach position. The one of the most important, the lung head ratio, then total lung volume, which is usually calculated on MRI. And there are certain new prognostic indicators which I will enumerate only, not going into the details. But few of these I am going into the details. So age of gestation, why this has a poor prognosis? Early herniation means lungs were compressed early, and due to critical branching phase, there is developmental delay, and then pseudocardiac stage, there will be the arrest of further development of the lung. This leads to fewer bronchi and branches and fewer alveoli, and thickened pulmonary vasculature. Early severe hypoplasia lead to the poor survival even with the ECMO. So this is one of the important question which is asked during the practical examination when you get a case of, or even if you get a X-ray of CDH. So usually prognostic factors are asked, what are the good or bad prognostic factors for CDH. So one of them is the age of gestation when it is diagnosed. Second comes the laterality of the hernia. Most common side you know is the left CDH. Though it is considered better prognosis, what are the poor prognosis in the CDH? Even on the left side, we will discuss in the subsequent slide. But if you compare the right side hernia with the left side hernia, right side hernia has the worst prognosis. The two reasons behind which is usually asked, and you will not able to tell the appropriate things why the right side is considered as poor prognostic factor. So one is liver almost always herniates and lead to the severe compression because it is a solid organ. Secondly, right lung is has a slightly more volume than the left lung. So in these two ways, it has a worse effect or bad effect on the prognosis. As you can see here, that the GB and this is the liver which is herniated into the thoracic cavity. Then comes the bilateral CDH. The bilateral CDH, though rare, but it is known, and only few case reports are till there now which have a survival of bilateral congenital diaphragmatic hernia. These patients have a severe pulmonary hypertension and frequently associated with syndrome which are incompatible with postnatal life. Then comes the position of the liver. Though we consider mainly when the ultrasonologists do the antenatal scan, they see whether the liver is up in the thorax or down into the abdomen. But the most important point which is to be taken for the liver is assessed by MRI because they quantify the amount of the liver which has been tugged up or displaced up into the thoracic cavity. So 2 or 3 meta-analyses they have seen the survival, the patient with the liver up and liver down has a statistically significant difference. So again, the point comes why the position of liver have a poor prognosis. The liver is large, solid, and non-compressible. When it herniates into the chest, it occupies the thoracic space needed for the lung growth. And in the solid, it pushes the mediastinum structures to the opposite side very easily. And this causes the ipsilateral and contralateral hypoplasia of the lung. And if you see these, upside of the liver is one of the strongest or strong predictor for using of ECMO in the patient in postnatal period. So, coming to the position of the liver and its severity index. Severity on USG, it is seen by 3T: liver up in the thorax, that is poor prognosis. Then liver partially up, moderate, partial obstruction, and liver down, that is good comparison to the other part of the CDH where the liver is up. Then important thing is, which I have told you, is on MRI. So liver herniation, the liver volume in the chest and total liver volume is calculated. And this liver severity has 2 points. It's a severe or mild. If it is index is more than 20 to 30%, it is a severe and has a very poor prognosis. If it is less than 10%, the prognosis is on better side. Next comes the position of the stomach. So how you diagnose echoic structure into the thoracic cavity? Kitano et al. Has described it 4 grading depending upon the position of the stomach into the thoracic cavity. If there is no stomach in the thoracic cavity, it is graded grade 0. Then grade 1 is partial is into the left side of the thoracic cavity. When a partial part of the stomach is going on to the right side of the thoracic cavity, it is graded as 2. And when the major or half of the stomach is on the right side of the diaphragm, in the diaphragm, thoracic cavity, it is considered as grade 3. So why the position of the stomach change the prognosis? It indicates that defect is very large. That means the stomach is there, some part of the solid organ may also herniate. Sometimes liver also herniate, as you can see here, there's the stomach as well as the leftover liver is herniated in the thoracic cavity, and these lead to no lung compression and hence the poor prognosis. So, position of stomach and the severity index, the grading of stomach, I have already told you. And then what we usually see is the severity, that is stomach in the thorax. So coming to the prognosis, if it is intrathoracic, the prognosis is fat, mortality is almost 59 to 51%. And if it is intra-abdominal, other things are absolutely normal, then the survival is almost more than 90%. The next comes the most important thing, that is lung to head ratio. It was thus described in Metcalf in 1956, in which the lung size of the contralateral to the defect size is measured. But this lung volume or lung size change with the gestation of the patient. So, observed LHR is considered more good prognostic factor than simple lung to head ratio. So, known with that they have a make a nomogram of the expected volume of the fetus, and compared to that, the present or the patient which we are looking on, the percentage is calculated, and this will define the prognostic factor of the CDH. So lung to head ratio severity index, it is divided into 4 groups, that is severe CDH, moderate, mild, and very mild. So if it is less than 25%, it is a poor survivor, and in this is one of the indications for FETO. Then again, the 25 to 34% is moderate as the intermediate prognosis, and which in the LHR is more than 35%, it has a good survival. If it is more than 45 to 50%, it is very mild severity and very low risk for these patients. One of the important findings, which is a factor which is calculated by using the MRI, which gives the most accurate lung volume estimation. And here we take the total lung volume. Again, same question as here, the different age of gestation, the total lung volume of the patient or the fetus is different. So a nomogram is placed, and the present lung volume and the ratio of the normal gestation or the patient with a normal lung or without CDH, the volume of the lung in that patient is taken and is considered as observed TLB percentage. Again, same thing, direct quantification of the lung dysplasia, smaller bronchi, fewer alveoli, reduced vascular bed if the volume is less, and this lead to the high PPN NH risk. So once we count that, it is again divided into 4, but in some books it is divided into only 3 categories, that is less than 25%, 25 to 35, and more than 35, with a survival rate of 13 to 80%, 83% almost in these cases. Now again, there is one of the new score which is now commonly used at certain places, is the herniation score. That is also calculated on the MRI. So the herniation volume of that is volume of the herniated organ divided by the thoracic volume is a indicator which gives the prognosis. If it is less than 0.06, it is very severe. Between 0.3 to 0.6 it is moderate, and if it is less than 0.3, it is considered as mild severity. Coming to when we combine the two things. So in this, LHR and liver up and down. So if LHR is less than 15, it is incompatible life. If it is between 16 to 25%, it is considered as severe, and the degree of pulmonary hypoplasia in this case is very severe, and the estimated survival is around or less than 20%. If LHR is 26 to 35 and liver is down, it is considered moderate hypoplasia. But if it is 36 to 45% and liver is up, again, degree of pulmonary hypoplasia is less and survival rate is around 30 to 60%. But when the LHR is more than, it's between 30 to 60 or 45, but liver is down, or if the LHR is more than 45, it is there is pulmonary hypoplasia which is very mild, and the survival chances is almost 75%. Again, take the prognostic value, LHR, difference range is 1.8 to 3. So we can predict why this table is important to counsel for the patient. When you are seeing this patient and you have to counsel this patient, these charts are very important. But you have to counsel the patient regarding the postnatal life of the fetus. So if LHR is 1.2, these patients are very difficult to manage and they may need ECMO in the postnatal period. Probability of death is 100% if LHR is less than 0.9. If you consider the total lung volume, if it is probability of ECMO is required if it is less than 25 ml, and almost 100% postnatal death if the volume is less than 9 ml. There are certain other tests which are also predictive postnatal severity of the CDH. It is one of them is hyperventilation test, and it is usually useful after 28 weeks when the alveoli or lung stage of development is beginning. It is new parameters than in the Western society only. Then there are certain other prognostic parameters which are under evaluation. That is ratio of hepatic volume above the diaphragm and to the liver volume, total liver volume. Then liver intrathoracic ratio, that is herniated liver volume to total thoracic volume. Lung area, quantitative lung index. So coming to the summary of antenatal prognostic indicator. This is one of the important questions which is asked during the Viva Voce, or it may come as a short note. Till what I have taught to you, most of these questions come as a short note. Lung development, the diaphragmatic development, then what are the prognostic factors for or indicators for the congenital diaphragmatic hernia. So coming to the prognostic indicator, that is OE, LHR, good prognosis or poor prognosis with less than 25%. Liver position, we have already described. If liver is down, it is a good prognosis. If liver is up, it is a poor prognosis. Total lung volume, if it is more than 45%, good prognosis. And if it is poor, it is less than 25, it is poor prognosis. Hernial side or laterality, we have already described that left has a good prognosis. Right and bilateral have a poor prognosis. Stomach, if it is up, it is a poor prognosis, but if it is down, it's a good prognosis is good. Genetics, we have already described. Normal is a good prognostic factors, where abnormal has a poor prognosis. Similarly, the associated anomalies, growth, and the fluid, that is polyhydramnios, has a poor prognostic factor. I will summarize the severity index also, which are the main important things is lung to head ratio, mild, moderate, and severe. If it is more than 35%, it is mild. If between 25 to 35%, it is moderate. And if it is less than 25, it is a severe defect. Similarly, TLV, if more than 40%, is a mild. And if it is less than 25%, is severe. Similarly, the stomach position, that is grading 1, 2, and 3, and side the right and left or bilateral. So, what is the natural course of the patient? 5 to 8% are stillborn, and around 80% have an immediate presentation, and then late presentation is seen in 10 to 20%. And overall progress in the Western world is 16 to 90%. But as I told you, the Indian city, the average survival is around 59% in Indian scenario. Now, coming to the prenatal management. So, as you've told you, when you have suspected CDH, confirm the diagnosis by ultrasound. If you need, or if your center is well equipped, you can go about MRI, and if required, the fetal echo. Once assessment is done, that you are confirmed that CDH is there, further assessment is done by liver, seeing the, now coming to the prognostic points, and you have to consult the parents as well. So do the ultrasound, see the liver position and LHR. If it is going in the wrong direction, that is severity level, try to get the MRI for the liver and fetal lung volumes to consult the patient. And if it is on the poorer side, it is better to get karyotype and associated anomaly scan. Once it is done, assess the prognosis, discuss with family the options depending upon the age of gestation. Though I have told you it is very difficult to diagnose CDH before 16 to 18 weeks of gestation. So once it is done, now comes the therapy. Now we have to decide whether you are going away for expected management with severe surveillance. If it is like that, then consider for prematurity, sometimes gestation is less than 34 weeks, put the steroids. If it's a severe case, as I told you, which we will discuss in the subsequent slide also, what are the indications for the prenatal interventions. Fetal therapy may be undertaken for the severe cases, experimental. Then termination of pregnancy, if you have assessed the patient properly with the genetics and the associated anomalies and the cardiac defect, if it is on severe side, you may consider the patient for the termination of pregnancy. Serial emergency, low FLU, cesarean section at 37. No anomalies, isolated defect, normal FLB, then delivery at 38 weeks onwards. So, why there is need or indication for prenatal intervention? I have already told you what is the fate of the CDH. So, what is need of prenatal intervention is pulmonary hyperplasia. These patients have pulmonary hyperplasia, pulmonary vascular abnormality, and a poor survival. This is the need why we have to take the prenatal counseling or prenatal intervention. So, coming to the indications for the prenatal intervention, that is, if LHR is less than 25%, liver is up, and then there is no major. So one of the most important contraindication for fetal intervention, if the patient is associated with major other congenital abnormalities, or he has a major genetic defect, so fetal intervention is usually avoided because the patient is not going to survive anyway. So gradual improvement seen after ballooning inflammation, which we will discuss in the subsequent slide. So you are aware what are the different antenatal programs which can be used. It is the least invasive of all options, that is FETO. Performed percutaneously and therefore general anesthesia is usually not required. A thin walled flexible Teflon cannula is inserted depending upon the gestation and the severity, either between around 27 to 30 weeks or 32 to around 32 weeks. Once it is placed just before the delivery or at the delivery, do an exit procedure and it's a time for removal. Another is Fitendo that allows the dissection of fetal trachea and placement of the operating clip without hysterectomy. This procedure avoided maternal hysterectomy, although maternal laparotomy was still performed. So depending upon the condition and the equipment of the specialty which is developed, these features can be done. At our place, we have seen only one FETO, not Fitendo, in our center. So this is
This animation shows a prenatal intervention of a congenital diaphragmatic hernia or CDH using fetoscopic endoluminal tracheal occlusion or FETO. One thing to note is that it's difficult to determine with imaging exactly how large the hole in the diaphragm is. As we'll demonstrate here, what we can see more clearly is the size of the chest and how the lungs are affected. What you're seeing here is a fetus who has no defect in the diaphragm, and the anatomy is normal. In a mild diaphragmatic hernia, as shown here, the left lung starts to shrink in size. Moving up the scale of severity, next we see a fetus with moderate diaphragmatic hernia. The left lung is getting smaller as the intestines and part of the liver push upwards. In the most severe cases, as shown here, the liver is occupying a good portion of the chest. The left lung is very small, and even the right lung is shrinking. Babies with this degree of severity of diaphragmatic hernia are good candidates for FETO, which may help to grow their lungs and improve their outcome. The tracheal occlusion procedure is commonly performed at the gestation age of between 27 weeks and 29 weeks and 6 days. Under ultrasound guidance, we give the baby a shot of medicine that includes pain medication and paralytics. A local anesthetic with numbing medication is injected into the mother. We then insert an introducer into the amniotic space. This allows us to place a fetoscope or a small camera through the introducer into the amniotic space. Once we locate the baby's mouth, we advance the fetoscope carefully into the fetal trachea or the windpipe, ensuring the scope is in good position. The ideal position is in the main trachea below the vocal cords, but above the carina before the trachea splits into the two main bronchi. We then insert a balloon into the airway. The balloon is inflated to completely occlude the trachea before it is detached and left in place. We confirm the proper position of the balloon before the fetoscope is removed. The balloon is left in place for a few weeks to accelerate lung growth. Usually at 34 weeks gestation, the tracheal occlusion is released using one of two methods. If the baby is in proper position, we can puncture the balloon under ultrasound guidance as shown here. The deflated balloon is pushed out of the baby's trachea by the lung fluids and poses no risk to the baby's health. If needle puncturing is not possible, we use a grasper to hold on to the balloon while a needle punctures the balloon. The deflated balloon is then removed from a baby's airway using the grasper. The mother and fetus are then monitored carefully for the remainder of the pregnancy. Ideally, the baby is delivered vaginally at term with a C-section reserved for the usual obstetrical reasons.
So that was one of the animated video for the FETO, and thanks. I have completed my presentation. I'm ready for any query which you want to have. Hello, Aditya.
Thank you, sir. Thank you very much for that excellent session. I think there are no queries, sir.
No questions. Okay. So, in fact, I thought that it will take around 1 hour, 20 or 30 minutes, which will be a bit longer. And But I think a longer session is sometimes difficult to pay attention. So, next part, as Deprabha has told me, that is on the 19th.
Next Friday.
Yeah.
Yes, sir.
Therefore, I will try to cover the postnatal symptoms, then the pathophysiology behind it, and then what are the intervention which can be taken, what are the things which when we are doing thoracoscopic or abdominal approaches, if the diaphragm is not going to be closed by its own or by the suturing, what are the other options? This we will discuss in next session. Hope it was informative to you people.
Yes, sir.
Okay, anything then?
Sir, what do you think are the scope of fetal surgery in India, sir? Look, do you do it at your institute, sir?
That I told you, we have seen only one patient here, for the CDH at least. But for like PUB, we are till recently we are doing vesico amniotic shunt, but nowadays that shunt is not available. So that procedure is not yet not done at our place now. At our place, we did a few, not exact fetoscopic, but exact procedure we have done at our place, 2 or 3 cases, and that are mostly for the large cystic mass in the neck. So that is, I'm not very aware where it is done. Only what I heard is Ryan sir is doing certain fetoscopic work, and someone in Bombay are doing. I'm not aware of what they are doing at their place. At your place, Devaba, in Jodhpur?
No, sir, no fetal surgery as yet in our department. Very recently, we had done an exit procedure for a cystic hygroma baby.
Same thing. We have done 2 or 3 cystic hygroma and one teratoma in the neck, which was done for the exit procedure. In last 5 years, we have done 3 or 4 cases only. Anything else?
Sir, sir, what are the indications for MRI, sir? After we diagnosed it antenatally with the help of ultrasound, if we find that all the parameters are in favor of CDH of moderate to severe intensity, like observed to expected lung to head ratio, liver to head ratio is 25 less than 25, then we should proceed with MRI, or just we can convince the parents on the basis of ultrasound itself.
So, on the basis of ultrasound, you can prognosticate or counsel the patient. But nowadays, you know that most of the patient want a definitive what is the most perfect thing. So, if the patient is asking for a lot, furthermore, you should go for MRI. But if you are able to see that stomach is up or liver is up, in these cases, along with USG, you have to go ahead with the MRI.
Yes. Sir, there is one question.
Yeah.
Role of steroids in CDH. At what week we need to start steroids and how are the results?
Thing is that I've already told you after 32 weeks, around 32 weeks, if there is chances of prematurity, at that time you have to give the steroids. That is only for the lung development. It doesn't help in the decrease or decrease in the CDH. It is only for the congenital lung maturity.
And sir, I had one more query. In FETO, sir, we will inflate the balloon in the trachea,
Yeah.
and then when to puncture that balloon, sir? Like after how much interval of time?
So there are 2 windows. One is between 27 to 29 weeks. So at the 27 week, you put the balloon, in the more severe cases, and 29 to 30 weeks you have to puncture it. And then second window is between 30 to 32 weeks. At that time, when when you initially thought that the patient is doing bad, but suddenly you think that the patient lung volume is decreasing, or you suddenly saw that the more containment is circulating into thoracic cavity. At that time, at 30 weeks, FETO is introduced, and then it is usually removed at the 32 weeks, or at the time of exit you can remove it.
Okay. And sir, there is one more query, like any emerging biomarkers for prognostications?
In fact, I'm not aware of biomarkers. The radiological sign I'm aware of. I have to search it. I didn't think there is in literature it is shown any biomarker. Let me think. No, I have not seen it.
Yes.
In fact, I have not seen it.
Yes,
Mostly these are the radiological parameters which are used to communicate. Biomarker. Some people say that maternal serum alpha protein may help in prognosis, and there are certain amniotic fluid markers. In fact, I'm not well aware of those markers. They are not. They are under evaluation, but not standardized. People may say that chromosome analysis and other things, they may consider it as a biomarker, but in fact, they are not the biomarkers. They are genetic testings only to rule out other abnormal or genetic disorder which are incompatible with life. So there is some research going on the amniotic fluid parameters and maternal alpha fetoprotein levels. But details I am not aware.
Yes, sir. Any more queries? Sir, I think there are no queries, sir.
Okay, thank you, Aditya and Baba.
On behalf of this IAPS NextGen team, sir, I would like to express my sincere gratitude. Thank you for this amazing session, sir.
Thank you, sir. It was
Thank you.
very insightful, very informative.
I think it will be helpful for your preparation.
Yes, sir.
How much it will be good for you. But I prepared it for mainly for the biology and the question short notes, which usually comes in the examination.
Yes, sir.
Okay, Devprabha. Okay, Aditya.
Thank you, sir.
Thank you, sir.
Good night,
Thank you,
sir.
sir. Good night.